Good morning. Welcome. Today is the last day of our Congress. So we are happy to be here and welcome Hamid for start our session.
Good morning, everyone. It's just fantastic to have you here early in the morning on the last day of the conference. I'm going to be co-chairing this session with Professor Wei Hao from China, and we have a really good set of speakers from around the world. The first speaker is going to be Yingji from Shenzhen Institute of Advanced Technology, and then we go to India, and Samir is going to discuss about the circuits and the specific executive parts of the circuits that he's addressing in India, and then we go to Dr. Hao discussing about other neurocircuit targets, and I will try to put those things together and discuss about the future of the clinical use of brain stimulation in addiction medicine. So without any further ado, we'll start with Dr. Zhu. Please.
Yeah, thank you for coming. Yeah, I would like to thank Professor Wei Hao and Professor Hamid for organizing this symposium and inviting me. And it's exciting to present in this wonderful place. So my title is the neurocircuits to be targeted for addiction treatment. There is no conflict of interest in my presentation. So my talk will include 3 parts. First, I will give a brief overview on the neurocircuits underlying drug addiction and current neuromodulations for addiction treatment. And then I will present a study from my lab showing how basic research can provide novel brain targets for addiction treatment. So as we know that addiction is defined as a chronic relapsing disorder that is characterized by compulsive drug seeking and use despite negative consequences and long-lasting changes in the brain. Here I show you are some commonly abused addictive substances: opioid, psychostimulant, marijuana, and some legal substances such as tobacco and alcohol. So what's the driving force for drug addiction? When the subject takes the drug, they experience euphoria, the rewarding effect from the drug, which may then continue to pursue the drug for such effect. This is the positive reinforcement. When they regularly take the drug and the dependence is found, once they try to quit, the withdrawal symptoms will show up. So they have to take the drug to avoid the painful withdrawal symptoms. This is negative reinforcement. Both positive reinforcement and negative reinforcement contribute to the relapse. So we will have 3 stages of addiction cycle: the reward, the withdrawal, and relapse. Understanding the neurocircuits mediating those processes is important for developing effective therapeutics. The brain's reward circuit is the main target of the addictive substance. So addictive substances like nicotine, opioid, and cocaine, they can directly or indirectly act on this reward circuitry. At the core of this reward system is the dopamine neurons in the ventral tegmental area, the VTA. And those addictive substances can act on dopamine system and increase the dopamine concentration in the brain. However, in the chronic drug use, the brain's reward function was impaired, as shown by this reduced dopamine receptor 2 availability in the cocaine addicts and the blunted dopamine release in the brain in the cocaine user. This impaired reward function might contribute to the lack of interest in non-drug-associated activities. Drug withdrawal can trigger activation of extended amygdala, including BST, the central amygdala, and maybe the share of the accumbens. And it has been shown this stress and anti-reward system, the function was elevated in the addiction. Here I'll show you the animal study showing the elevated corticotropin releasing factors in the BST was increased following ethanol withdrawal. And my previous study showing that a synaptic connection between PVT and accumbent D2 cells get potentiated following opioid withdrawal. This elevated stress and anti-reward system might contribute to the negative effects during the drug withdrawal. Drug relapse also involve distinct distributed neurocircuits, including extended amygdala, ventral VTA, BLA, prefrontal cortex, and then accumbens, eventually leading to the drug release. And it has been shown that the prefrontal cortex, which is responsible for the executive control function, was weakened in both human study and animal study. So here I'll give you a brief summary of the neurocircuits involved in the addition. And I want to emphasize that the dysfunctions in the addition, including the impaired reward function, elevated stress or anti-reward system, and weakened executive control function. So because of those dysfunctions, we could able to use the neuromodulations, the physical stimulations, to rebalance those dysfunctions in the brain circuit. And this can help to treat addiction. The neuromodulations including non-invasive approaches, including TMS, DCS, FUS, and invasive neuromodulation like DBS. I'm not going into the detail about these neuromodulations because we have 3 experts will be presenting those topics. So TMS, transcranial magnetic stimulation, has been shown to reduce the nicotine, the smoking. And the DCS, the transcranial direct current stimulation, has been shown to reduce craving for multiple substances. The DBS is a promising intervention for addiction treatment, which is invasive, involves neurosurgical procedures to implant electrode. The nucleus accumbens is the most targeted brain area for addiction treatment for the DBS. And the double target stimulation developed by Sinray also been shown to be effective in preventing opioid relapse. The focused ultrasound stimulation, which delivers the ultrasound to open mechanical channel in the cells to modulate the neuronal excitability, has been shown to reduce opioid craving. So now I will give you an example, a research from my lab showing to how the basic animal research can provide novel brain targets for addiction treatment. So in 1954, Aldous and Miller discovered the brain's reward system by their pioneer intracranial electrical stimulation. At the time, they reported that there are many brain regions support self-stimulation. However, the septal area stimulation produces extremely strong reward. The responding score is even higher than many other brain areas, including VTA, where the dopamine neurons located. However, the question remained, what's the neural substrate for septal electrical stimulation reward? Because the electrical stimulation cannot distinguish cell types and passing fiber. We decided to use modern optogenetic approaches, which has the cell type and pathway specificity. So with the specific expression of ion channel, CHR2, the light-sensitive opsin in a specific group of neurons, we can achieve the specific activation of a particular group of neurons. To delineate the cell compositions in the septal area, we use single-cell sequencing to characterize the transcriptional profiles in the septal area. We identify 15 neuronal clusters, each with distinct transcriptional profiles and molecular markers. Most of them are GABAergic neurons, 2 are glutamatergic neurons, and 1 cholinergic neurons. After screening, we focus on 3 neuronal types. The one expressing estrogen receptor located in the ventral part of the LS, the neotensin expressing neurons located in the intermediate part, and the somatostatin neurons located in the dorsal part of the LS. With the mouse crit line and the code-dependent wire strategy, we specifically express channelosine in the ESR1, NTS, or SST neurons. So then we can specifically activate each neuron. We found that activation of ESR1 neurons produce positive reinforcement. The mice will keep responding to get the stimulation, and they will spend more time at the light pale side. However, activation of NTS or SST neurons has no such effect. Interestingly, we found that the methamphetamine, the meth, can induce robust dopamine increase in the septal area. However, the natural reward like chocolate consumption or social interaction fail to induce any dopamine concentration increase in the LS. This is in stark contrast with the classical brain area like nucleus accumbens. In accumbens, both drug and natural reward can induce dopamine release. Yeah. So this suggests some specificity between the drug and the natural reward in the LS. Yeah. So we decided to inactivate LS-ESR1 neuron, and we found there's no effect on natural reward. The food seeking is the same, and the social interaction index was not different from control. However, this inactivation can completely block mass reward and seeking, as shown by this mass self-administration, condition preference, and the locomotion, hyperlocomotion. And we found that chronic mass treatment can increase the neuronal excitability of ESR1 neurons. This is by the upregulation of HCM1 channel. We designed a shRNA to specifically knock down HCM1 channel in the LS-ESR1 neurons. And we found this can significantly block the mass high locomotor sensitization without affecting mass reward, the CPB score. And also, we infused the antagonist of HCM1 channel into the LS. And this can also block mass-induced sensitization without affecting mass reward. We also silenced the ESR1 neuron during the cue-induced mass relapse. And we found this silencing can completely block the cue-induced mass reward. So in summary, we identified the transcriptional profiles in the septal area. And we found that ESR1 neuron promote positive reinforcement and play a critical role in mass reward and mass relapse. So this suggests the LS could emerge as a promising target for additional treatment. So this work has been published in Neuron last year. At the same issue of Neuron, Professor Yavin Shaham from NIDA gave a comment on our work. Yeah, he said when James Aldous and Peter Milo are no longer with us, their groundbreaking work continues to inspire, and they will likely be very impressed by our exceptional study. Yeah, well, I would like to thank people who did the work in my lab and funding agencies. Thank you for your attention.
I think this is a good presentation. And Dr. Zhu is a young neuroscientist in China, have done a lot of work in this area. Do you have any comment or question for his presentation? Yes.
Yeah, thank you for the wonderful presentation. You mentioned that one of the target neuron is also estrogen. So you mentioned in the slide.
Which one? Which part?
The target neuron.
Yeah.
One of the target neuron is also estrogen. So
estrogen
receptor. So
yeah.
It will it be different between male and female activation for neuromodulation in the brain with addiction disorder?
Yeah, thank you for the question. Yeah, it's very interesting. Yeah, we don't know the answer yet, but there are some studies showing that female actually are more vulnerable for addiction. Yeah, and I think the estrogen level change in the physiological cycle, so this could also modulate a female's behavior and their susceptibility to addiction. Thank you.
And the second question, what do you think about induced lateral septum for a patient with behavioral addiction like gambling disorder? Because you mentioned it's for methamphetamine use, but what about for gambling disorder with induced lateral septum?
Gambling?
Gambling.
Yeah, we don't know yet. We cannot do experiment on human, and it's hard to train animal to do the gambling.
Okay, thank you for Dr. Zhu.
Yeah, thank you.
Our next, thank you. Our next speaker is Dr. Somakama Prahaja. Dr. Prahaja comes from India. Now, his topic is frontopolar cortex as a target for neuromodulation in addiction treatment. Now, welcome.
Good morning, everyone. At the outset, I want to thank Professor Vayo and Professor Hamid for giving me this opportunity. So it is nice to talk to you today. I'll be speaking on DLPFC as a target. I think Professor Hamid will be talking more about the frontopolar cortex. So no conflict of interest. I have a funded project. So before I start, just a glimpse of about India. So India, as you know, I think the most populous country now in the world, and we have a very large segment of young population, and there's a lot of diversity in India. So although India is a single country, there are so many states and so much of difference between the states. So different languages, different culture, different food. So it's actually quite challenging when we talk about addiction. So the complexity, the psychosocial complexity is quite high that way. So about the problem, like in other places, so tobacco, alcohol are the two most common substances used in India. Cannabis, opioids are the next ones, but much less. And fortunately, we don't have cocaine and those kind of stuff. The treatment gap is huge, and like in all other places, mostly because of lack of knowledge. I'll tell a little bit about the services that are available in India. So there's a very poor understanding of addiction among Indians, not just the patient, but even other professionals. Most people don't accept addiction as a disease as such. And there's a wide variation in services. So there are government setups, there are private setups, NGOs, but then the quality of services vary widely. And treatment options, as we know, are quite limited. So pharmacotherapy, we have very few for these conditions. And psychosocial treatment, of course, it is there, but then because of lack of trained manpower, it is not widely available to everyone. And we know about the treatment retention rates, which are quite low in addiction per se. So community services are again restricted to few institutions. The cost of care is another problem. So government funds only very small proportion of the care of patients, and specifically with addiction. So most of the expenditure is out of pocket. So with that, we'll come to the addiction. I'll not discuss about the characteristics of addiction. All of you know about this. I think last 2 days we have been discussing about this. In the previous presentation also you heard about the circuits. So, but two things which are very prominent in addiction, patients who are addicted, one is cue reactivity, which is chronically remains elevated. And the other thing that we know is the involvement of the frontostriatal circuit, which basically would be the target for neuromodulation. So we need more treatment options, and neuromodulation offers one possibility. The ones which are commonly used now, because I'm a clinician, so I'll be talking more about the actual uses that we do, not talk much about the animal models and other. I'll leave it to other people who are working in the field. So the three most common which are currently available and being used, RTMS and tDCS are the ones which are commonly used now. And DBS, again, there are very few centers. There's not a single center in India which actually does DBS for addiction. Maybe for OCD, there is one center which works. So it is mostly restricted to RTMS and tDCS currently as treatment modality in India. And we know it is not just the primary effect. So if you are targeting a particular area, usually with TMS, tDCS, we will be targeting mostly the superficial areas of the brain. So it is not just the primary area where we are targeting, but there are distant effects which are there, which we know because of the circuits. A little bit about neuromodulation in India, the services that are available. So although in psychiatry, we started using neuromodulation in early 2000, I think 2003-04, that is where we had a series of early trials, TMS trials in different disorders, including alcohol dependence. So mostly we are targeting DLPFC for all the other conditions, not just addiction. For depression, for OCD, for all conditions, the major focus was DLPFC. And these were some of the early publications from CIP Ranchi, which is one of the premier institutes in India. And the services, if you see, so initially it was restricted to 2-3 premier institutes like NIMHANS, CIP Ranchi, AIIMS Delhi, PGI Chandigarh. But then now it has become much more widespread. I work in a private medical college, and now we have a neuromodulation lab there. We have several private clinics who are offering neuromodulation services. Several training programs have started lately. We have formed a Neuromodulation Society of India in 2018. And there are now multi-center collaborative research projects also in neuromodulation. And so that is maybe a beginning of interventional psychiatry in India. Now coming to the topic per se, so DLPFC, the prefrontal cortex, if you see, although there are different areas which are involved, from the perspective of addiction, I think we can just group them into two parts. One is the DLPFC, which is mainly associated with executive control, and the ventromedial prefrontal cortex and orbitofrontal cortex, which is mostly associated with reward. And I think we have already been discussing about this two-system model, where the control and as well as the salience part is basically it's basically taken care of by these two systems. So so if you plan any intervention for addictions, so there are two major strategies. Although we discussed yesterday, there are multiple new things which are coming up. Two strategies which are quite prominently used. One is because the DLPFC, the control part is not functioning properly, so you want to let's say use excitatory stimulus to activate it, and the overfunctioning reward system which you want to dampen using inhibitory stimuli. So these two approaches we'll be using mostly, either separately or in combination. And if you're using TMS or tDCS, so we know we can have excitatory or inhibitory stimulation using both TMS and tDCS, which we use. So it's not just the structural imaging which helps, but then now with the current understanding with fMRI, yesterday we had a full discussion on use of fMRI. So there are three major networks which have been identified, which are important in addiction. So one we know is DMN, that is a default mode network, which is mostly in the resting state when there are introspective functions. And there is a second network, which is salience network, which is more like a switch between the DMN and the frontoparietal network. So it acts as a switch. So from a resting state to more active state, so it acts as a switch. And the third one we all know is BMN, ventromedial network, which is the reward pathway. And also understand now that this ventromedial network and the salience network are opposite. So they have a completely different opposing role. So what are the different disruptions that we see in substance use disorder? One is the salience network that is hyperactive. And there are certain areas like insula and anterior cingulate cortex which are hyperactive. And BMN is overactive. So these are some of the findings that we see. And based on this, the treatment also has been conceptualized as basically targeting different states. Here you can see how from the salience formation to the executive control, so you can target different areas. The two most important ones I already said, let's say hyperfunctioning salience network which we can dampen using inhibitory stimulus and excitatory stimulus for executive control. That is something that we can use. So enhancing cognitive control we can do by targeting DLPFC. Essentially, we are targeting the salience network indirectly. So if you see the salience network, DLPFC is also a part of the salience network. And we are using excitatory stimulus, TMS or tDCS for that. But we also know that the insula and anterior cingulate cortex are more important than DLPFC. Possibly, if you can use those areas also, and that has also been used. I mean, if you're using a deep TMS with the superficial stimulations, TMS and tDCS, we may not be able to access those areas. There is another thing that we see is dorsomedial prefrontal cortex, which is again something which is being studied in depression. So you see there are some patients who respond to DLPFC stimulation, whereas some patients who respond preferentially to DMPFC, the dorsomedial prefrontal cortex stimulation, specifically those who have anxiety along with depression. So something like that possibly we need to explore in addiction as well. And of course, reducing the incentive salience. So BMN is the ventromedial network is the target. So, but we need deep TMS for that, targeting that. But another area which is emerging is a frontopolar cortex, which we can still access using TMS. So the other modality that we can use is inhibitory stimulation. So, inhibitory TMS we can use for frontopolar cortex. And sometimes we can actually target this network, ventromedial network, through frontopolar cortex inhibitory stimulation. But maybe some patients may not respond to this and possibly will require even direct targeting of the VMN. So if you see now what are the different targets that have been used in studies. So this is a compilation which shows basically the dorsomedial prefrontal cortex is the most common target. And DLPFC is not just a small area. So clinically when we target, we'll be using either F3, F4, EEG locations, or possibly using a more specific beam F3. But then DLPFC is a big area. So which area exactly you are targeting? If you're using more neurotargeting using MRI or even functional MRI, possibly we could be individualizing the treatment more. So common protocols that we use for alcohol use disorder, TMS, so again targeting DLPFC, more to right DLPFC, and same for tDCS, so we'll be using more of anodal tDCS on right side. So that is for alcohol, but then for tobacco, the laterality is different. Studies have shown that if you're stimulating on the left side, the results are better. So for other substances also, it is mostly the right side, same like alcohol use disorder. And like I said, frontopolar cortex, I'll not talk about this now. But are these effects very consistent? So there are many different effects that we see. So sometimes when we use actually an inhibitory protocol, but then it turns out to be excitatory in some patients. So this is something we need to also study. Possibly we should be doing more plasticity measurements and then see whether if you're actually using excitatory stimulus, actually whether there is excitation or there is inhibition. That also we should be studying. And medications also have a lot of effect on the efficacy of TMS. That is again poorly understood, so possibly we need to look into that aspect as well. The differences in anatomy and physiology in individuals so could actually be different. So that is why individualized treatment could be better. And the other thing is the brain state, which is we started understanding lately in other disorders, and same thing for addiction as well. So like for in OCD, if you want to treat obsessions, so one way to do that is you induce obsessions and then during that time you treat it. So possibly the results will be better. The same way in addiction, so if you're looking into cue reactivity, you actually induce cue reactivity So you show them the cues and then possibly use the nibs, possibly that will have a better result. Same way, if you're targeting executive control, because traditionally we have been discussing more about craving, but then actually we should be also measuring executive control. And if you can actually engage the patient in any executive control task when you're actually giving TMS or tDCS, possibly the results could be better. So the brain state is something that we have been overlooking. Possibly we should be focusing more on that. And this is actually seen in other studies in nicotine as well. The other aspect is optimizing the treatment protocols. So the initial studies, people are using around 10 sessions, and we just demonstrated some effect. But then now we know that for other disorders as well as in addiction, minimum 20 to 30 sessions in acute phase is needed to demonstrate some effect. And if the person actually responds, so why not even continue it further? So that is something, again, has not been studied very well, but then, and we can always offer them accelerated sessions, more number of sessions in a single day to reduce that inpatient treatment period. So you can use theta bar stimulation, which is useful that way. So maintenance sessions is something that need to be studied further. So in our center, we have been offering maintenance sessions to people who actually have shown some improvement in acute phase. The other thing is phenotyping the patients. Possibly different phenotypes could have different responses, those with comorbid personality disorder, those with other comorbid disorders. So possibly we need to again identify which particular phenotype would respond to a particular treatment. So individualized targeting is something I think Professor Hamid will be talking more about. I'll not discuss. In summary, if you see, NIBS, there is a good evidence for alcohol and nicotine, but yes, many other disorders, you heard about methamphetamine, opioids, other disorders also it is coming up. We maintain a registry in our center, so very few patients we have in addiction per se. I look into other disorders as well. So it's still feasible. I mean, the acceptance is around 50% of patients would actually accept and continue on the treatment, and there is significant improvement in patients, and some patients we are able to retain for slightly longer period. One of them had actually behavioral addiction as well. So the other thing that we should be discussing about the stepped care approach, because this is something that need to be studied. So we can offer, I mean, depending on the services available, so we can offer them conventional TMS or tDCS and maybe accelerated protocols initially. But then we should, if they're not responding to the initial treatment, possibly we could offer them alternative treatment as well, like targeting dorsomedial prefrontal cortex, frontopolar cortex, so that way. And possibly then maybe deep TMS also in some patients. Combinations, I think we heard about that, maybe two areas we could target. We can use precision protocols using neuronavigation, so those could come at a later phase if person is not responding, and maybe experimental protocols like even quadrupulse stimulation, maybe in the end invasive neuromodulation. So just to conclude, so NIBS is a promising treatment in substance use disorder. There are many newer targets. You heard about new targets which are coming up. So it's not just DLPFC anymore. And individualized treatment could be better to reduce the variability in response. And phenotyping of patients is very important because that could actually guide us who would receive which kind of treatment. More number of sessions may be required in the acute phase, and consider maintenance treatment for people who respond initially. This is my team. Thank you.
Okay, can take few questions, one or two questions. Please.
Thank you so much for your talk. Anastasia Demina, I'm an addiction physician from Dijon, France, and we do a lot of neuromodulation protocols in our center in alcohol use disorder and tobacco use disorder. And I completely agree that phenotyping and optimizing is really the future of neuromodulation, and one size fits all, it's not the most optimum approach. We just obtained the grant from French Ministry of Health for a little bit of a different protocol. It's not really maintenance session protocols, but we conducted a study with 10 tDCS sessions over 5 days, and we saw an effect that was persistent up to 6 months after the end of the treatment. So it was a small effect between active and sham groups, and we created the protocol of clustered tDCS because we repeat the sessions, like 10 sessions over 5 days, every month during 3 months. So it's not really maintenance, but it's clusters, with the hypothesis that this type of protocol would avoid metaplasticity effect. And I wanted to know your thoughts about the utility of this type of protocol.
Yeah, thank you. Yeah, you're right actually. So the effects could actually persist for some period. The problem is we don't know how long in a particular patient. So maybe on an average we could say 3 months, 6 months, whatever, but then in a particular patient the effect could wear off faster. The same thing that we see with ECT. So one way possibly is to look into some marker which could tell us that the effect is persisting. So I would actually suggest doing possibly plasticity measurements along with that to see whether it is actually persisting for that long. If it is not persisting, possibly you could think about maintenance. And maintenance again can be of either you can use cluster or you can maybe try tapering schedule, how we do for ECT, and now maybe for ketamine also we are doing the same. So we could try out those strategies and see. Yeah, like you rightly said, it's not just one solution for everyone. So you'll have to individualize.
Thank you so much.
Okay, now we go for the third speaker of the panel, Professor Wei Hao. And Professor Wei Hao is the regional representative of East Asia in ISAM. He has many, many different roles in different organizations, and we are delighted to have him here. Thank you very much.
Thank you. Thank you for your kind invitation for this very important session. My topic is rethinking psychiatry. Can DBS in addiction open a new research path? I'm Dr. Wei Hao from China. This is a declaration of my conflict interest. Today, I would like to talk about as a psychiatrist, our hope, our challenge, our disappointment. Second one, do we need to change your thought on psychiatry? Change the pathway for psychiatric research, and especially from DBS. And finally, summary and outlook. This slide show you, as a psychiatrist, we have a high expectation for biological study on psychiatry. Genomics, despite progress, no clear specific genetic markers can be identified. We are disappointed. And epigenetics, yes, but the limited clinic application. For the function MRI, we were very hope to provide can find the biomarker for the diagnosis and the prognosis, but no, not now. For the omic, is very complex, lack of actionable breakthrough. For the precision medicine, it's welcome, but it's not yet realized in our daily practice. This was disappointment. And why? I think a lot of the reason. One of the reasons is mind psychological phenomenon is hard to understand. I cannot imagine we use our thought to study our thought. It's understandable. Can we use our thought to study our thought? We use our consciousness to explore our consciousness. This is a philosophy problem we not explore here. Another sense is that we too much focus on the small part. We use so-called reductionism philosophy as I research thought. We try to break a whole sense into different parts. Then we start the different part. We put whole part together to understand the whole. It's quite difficult in our psychiatrists. It's too complicated. And as you know, our classification system is only based on symptom. And I don't think the symptom-based classification system can classify a real disease entity. No. So animal model, we try to use our animal model to replicate our disorder, but it's quite difficult. This is the reason why our gap exists. Can DBS as a both tool and therapy? I don't know, but this is my thought. The DBS may offer more than symptom control. It potentially allow real-time modulation of the brain circuits. Number two, it may enable exploration on the reward, craving, impulse regulation pathway in the control setting we just discussed in the two speakers. And I think thirdly, DBS can provide a possible bridge between the clinical effect and analyze the mechanism and supporting translational research. And finally, it may contribute the future development of circle-based diagnosis and intervention strategy for mental disorders. Here is my work we called independent third-party evaluation for DBS treatment on patient with opioid dependence. This is a two cross-sectional assessment for 26 patients post-DBS. The first assessment was conducted in 2021, and the second one was conducted in the last year and early of this year. And there were totally 26 patients, but in the first assessment, we only have 19. In the second one, it's only 18. So we, for the second assessment, about 31% drop out because of loss of the follow-up and voluntary withdrawal from the program. And the gender, the majority are male, and the mean age is about 45, and the mean years after implantation surgery is about 7 years. This is our assessment instrument for two part. One is for efficacy. We use hair drug test. We use the drug craving questionnaire. We use VR, a cue-induced craving test. And we also use the Barrett impulsiveness scale. And we try to understand the emotion regulation. We use the positive and the negative affective scale. For the safety, we use the Wechsler adult intelligence scale WIS for IQ. And for assess the personality change, we use the Big Five personality inventory. And we also ask our patient to self-report for their challenge, their problem, their benefit, and so on. And of course, all these are in the deep expert in-deep interview with video recorded. This is the main outcome. For the hair drug test, the participant lost to follow-up or voluntary withdrawal were counted as a positive. So the negative rate during the first assessment is about 65.4%. And the second one is almost 70%. I think this is a good result. It's quite long. And we ask our participant who quit the opiate, why you quit? There are 3 questions. Number one, you have a high motivation. You want to change. Second, your family give you, your community give you a lot of help on drug quitting drug. And thirdly, DBS help you. So about 50% thinks the first reason why she quit is DBS. And for the different neuropsychological safety, there is no significant impairment in the cognition, personality, motivation, and emotion regulation. Is quite safe. This is a single-arm study. We need to do the double-blind clinical trial. This slide shows you, I'm not a PI in this project, but as a consultant for this project. This project we called the bilateral DBS for opioid addiction relapse prevention. This is the multi-center clinical trial result. This is a clinical trial float overview. We have 31 participants for the informed consent. And we conducted the DBS implantation for 60 patients, 40 in the experiment group and 20 in the control group. And for the experiment group, after implantation 10 or 14 days, we give a real stimulation. For the control group, we give the sham stimulation. So we follow up. We random use urine test, and if the participant to reach the end point, for example, relapse, we unblinded and adjust the parameter for the experiment group, and for the control group, if they reach the end point, for example, relapse, we give the real stimulation. So we follow up this participant. the primary outcome for this clinical trial is abstinence rate at week 25 in the two groups. This includes criteria. This is exclusive criteria. This is the main efficacy outcome. It's very clear. By the week 25, abstinence rate was about 80% in experiment group and 20% in the control group. It's quite different. It's quite different. And the between group difference is the abstinence is quite high. It's quite high. And for the safety, of course, we have adverse event, but there is no significant difference between the two groups. For the device-related AE, five participants have the 9 DBS in 9 adverse event in the DBS group, and one participant in the control group. And the AE, adverse event requiring intervention, it's just the two groups are not different. And AE are usually mild and moderate without sequence. And there is no A leading to withdrawal. So the conclusion, a randomized double-blind trial confirmed that DBS target the NAC and ALIC is effective and safety in preventing opioid relapse. Second one, DBS improved abstinence rate, prolonged abstinence, and reduced craving intensity. This is my last slide. As a psychiatrist, and I think psychiatrists still face limited in understanding the treatment. We have a lot of challenges, as I mentioned. And DBS may help some patients with opioid addiction and offer the window into the brain circles. And DBS shows the potential as a research tool, link the symptoms with brain function. And further study are needed to confirm the long effect and broad use. Thank you very much. Please use your simple words if you want a question.
We can take your questions. Yes, please.
Thank you, Professor. Those are really exciting and promising results. Congratulations. My question is about the stimulation parameters. So you've identified a circuit, and the DBS is stimulating that circuit. How often and with what frequency of activation, and what do you think the result might be on that specific circuit?
This is a key question, how to adjust the parameter for the stimulation. It's very important. Different people have the different parameters. Personally, I think voltage is the first consideration. For the patient with Parkinsonism, about 3V is enough. But for the addiction, we need higher, 5, even 6 volts. The second one, I think, is the site. And I think there are 2 sites in the 8 site in the 2 target. And we try to ask our participant the feeling for each site for the stimulate, to ask their feeling, their emotion changes, and something like this emotion changes. It's immediately after right side. So this is maybe a good the parameter for stimulation. And, but a little, some people are tolerant for the simulation. So we need to adjust the parameter. So this is very important. Thank you.
Thank you. Just a quick follow-up. So were the parameters adjusted throughout the course of the treatment? Okay.
We can remote control to adjust the parameters. Even the patient at home, I'm in my office, we can remote control the adjust parameters. Thank you.
Thank you, Professor Wen Hao. So I would like to ask, is there any significant difference between week 6, 12, and 25? Because in our country, RTMS DBS is very expensive. If we will do that for 25 weeks, so it's very expensive for us. So do you find any significant difference in week 6 and week 12 before week 25? Is there any different significant result between, because you follow up in 6 weeks and 6-12 and weeks 25, but is there any significant difference between that weeks?
Well, this is the main result. And this is we call it the survival curve. This is experiment group. This is control group. So it's quite different. It's quite different. Thank you. This is the result of the week 25.
Awesome. Good. Thank you.
Thank you. Our last speaker is Hamid. The last is the best. Welcome.
Okay, hello everyone. My name is Hamid Ekhtiyari, University of Minnesota. I put my slides in the QR code. So if you scan the QR code, you will have access to the slides. So the question is, we have been discussing today about different neuromodulation technologies. We have been discussing about TMS, we have been discussing about the neurocircuits, using DBS to be able to target them. But the question is, how can we actually use neuromodulation in daily clinical practice of addiction medicine? Is it the prime time for it? And can we use the neuromodulation technologies in our daily clinical practice after this conference? Starting thinking, okay, we do not have in our clinical practice, let's just plan to have that in our daily clinical practice. So there are different brain stimulation technologies. How many of you in this room have touched any of these technologies that I'm showing above? Have you ever touched any of those technologies? Okay, good. So there are people who have access or have some personal experience with some of those technologies. Of course, we use ECT in daily clinical practice in psychiatry, most of the sites. But what about the other technologies? And how we might be able to use them in the actual clinical practice? And is this a prime time for it or not? So that's the main question I'm trying to address and the challenges that we are facing for that. So there are different brain stimulation technologies, as an example, electrical stimulation, magnetic stimulation, and there is a significant growth in these technologies. How these technologies are kind of evolving over the time, and there are many new studies in this field. But specifically for the field of addiction medicine, I think that we have 7 challenges to use these technologies in the actual clinical practice. And I'm going to address those challenges and conclude at the end whether it's a prime time to use it in the clinical practice or not. So that is the main thing I'm trying to address. Does it make sense? Sounds like a good plan for the end of the panel to be able to conclude and plan for the future. So these are the 7 challenges that I'm going to discuss about what is going to be the best target, how to individualize the targets, Are these targets reliable? How to optimize the targets based on the stage of the disease, whether they are in their first few years of their addiction, they are in something like their 20 years of addiction based on the stage of their addiction. How to optimize the dose, how we can optimize the state or the context of the stimulation and management of comorbidity. So these are the 7 challenges I'm trying to address in a very short amount of time that I have today. No conflict of interest. My lab in University of Minnesota is mainly kind of focused on developing brain stimulation technologies for addiction medicine. I'm trained to be a neuroscientist and psychiatrist, so I try to combine the actual clinical practice and doing the stimulation in a sort of daily practice. I work as a part of what we call medical discovery team on addiction, and this is a collaborative group of people that we have that we work together. Mark Thomas, who is the head of the team, is here. So we try to see how we can do things together, and there are definitely potentials for collaboration with other teams around the world. So we are definitely kind of welcoming any sort of potential collaboration in the future. Specifically using TMS as one of the most frequently used technologies right now in the field of neuromodulation. What are the applications for TMS that they have already received FDA approval? So we can use them in the actual clinical practice based on the FDA approval that we have. We have that for depression. What else? Bipolar. What else? OCD, what else? Tobacco, what else? Okay, so MDD 2008, OCD 2018, anxious depression 2021, a specific protocol, we call it accelerated protocol for individualized fMRI-based TMS. It's called SAND protocol 2022 for depression. And now age expansion for TMS from age 15 to 86. So these are the current approvals that we have. And also one specific approval on the smoking cessation in August 2020. And that specific approval is for a specific coil that mainly target an area that we call frontopolar cortex, okay? What do we have in Europe in terms of the C approvals that we have in Europe? And you know the standards for C approval compared to FDA approval is totally different. They have a sort of lower threshold to accept something for C approval. Specifically for C approval, there is a approval for using TMS for what they call psychoactive substance use disorder. And psychoactive means every substance use disorder, right? So substance use disorder in general, based on the studies that have been done mainly on cocaine use disorder and on left DLPFC. So far, left DLPFC and frontopolar cortex, they already have FDA approval or C approval, or there is a level of evidence for them. So discussing about the targeting biomarker, what is the right place to target? In depression, there is a reasonable level of evidence that potentially the network between dorsolateral prefrontal cortex and subgenual cingulate cortex, this interaction is one of the best targets to be used for clinical use in depression. And there are even companies that they patented specific ways of measuring that biomarker in the US, and there are few other companies that are working on that. So for depression, things are reasonably clear, and people have been working in the field of depression from at least 2008, so there's a huge amount of data that we have in the field of depression. But this is not the case for addiction. The level of data that we have in addiction is very limited. But people are considering this specific circuit. So today, we have been discussing about this specific circuit, or number of circuits that are important in the field. One is the executive control network, the green one, and then the other one is DMN, or default mode network. And it seems that when people are in the state of craving, the DMN is more activated. DMN and subcortical areas, not like nucleus accumbens, areas that are related to craving. And then when people go to the state that they have a level of control, they have an activation on executive control network. So it seems that when we optimize the balance between these two circuits, we can optimize the level of control and craving that people have. And addressing and targeting nodes of these networks, as an example, DLPFC as a node, or ventromedial prefrontal cortex or frontopolar cortex as a part of DMN network. When we target these nodes of these networks, we can modulate the balance between these two sides of these two networks and optimize the craving, okay? So we put together all the protocols that people targeted these circuits, and the question was, do we have enough evidence that these stimulations, they can actually change the level of craving that people experience? The slide is very busy, but just to give you, these are all the protocols that people use in different studies, okay? The ones that they have green lines, there is enough study, multiple studies that show that there is significant results. And as you can see here, the first line is left DLPFC with high frequency TMS. The one with deep TMS is the one that we have been discussing about frontopolar cortex. And then the other one in a TES or electrical stimulation, and it is mainly when you put the electrodes on left and right DLPFC and actually put the amount of electricity here. Because when you put the electrodes on the left and right with electrical stimulation, the majority of electricity would go here. So it seems that that sort of model that I'm discussing about today, what we call it dual target, it seems that these two major targets, frontopolar part and the DLPFC, these two targets, based on their connection to the subcortical areas, are the main targets in the field. Does it make sense? Okay, so we have a reasonable level of evidence that these two targets, they are working, and it seems that these two targets are working because of their connections to subcortical areas that are driving craving and urge. Okay, and these two main subcortical areas are nucleus accumbens and amygdala. Okay, so that is a circuit that we have that we target in the field. So we try to see how we can individualize, specifically targeting for each individual, and see is there any inter-individual variation in terms of how to optimally target these areas. One of these areas is the frontopolar cortex with its connection to amygdala. Okay? In a study with Ghazali, one of my postdocs in my lab, we explored that in a group of methamphetamine users, 60 methamphetamine users, and we explored whether the connectivity between amygdala and frontopolar cortex and the best target for each individual within their space, within the frontopolar space, would be different across different individuals. The dots that you see there, the red, yellow, the red, yellow, and the orange ones, the range that you see there are each of them one single MET user, patient with MET use disorder. And as you can see here, this is the X, Y, and Z axis, and these are millimeter. These are the numbers and the distribution of these areas. So it's pretty widely distributed across different areas of frontopolar cortex. And we showed that when we specifically consider these individualized connectivities to amygdala, the level of craving would be correlated to these individualized connectivities, okay? So this is the distribution of these areas around FP1 and FP2 in frontopolar cortex. As you can see here, it makes sense to have individualized targeting. Even we showed that the way that when you put the TMS coils over these areas, the orientation of the coil would matter in terms of how you can optimally engage these areas. And now we are trying to even use robots to be able to exactly target the right area for each individual patient and see how we can optimally do that. We have recently published that in addiction biology. The entire pipeline is already available there. So if you are interested, you can just look into that specific paper and we discuss and provide the details. But that is the idea in terms of for each individual patient, we can find the best target and optimally do the targeting. It can potentially improve the results, but I can tell you that even the group level targeting without that level of precision could potentially work. So optimization could add a little bit of further better results, but most of the stimulation methodologies that we are using, they are not that much precise. So it is still reasonable to consider even kind of not doing the individualization, while the individualization could potentially improve the results. But not only DLPFC and frontopolar, so there are other targets that we are thinking about in terms of the parietal cortex and other parts of that's the same network, and we are trying to optimally do that. But one of the challenges that people are asking, they ask, okay, if you find that a specific target in one area, and the patient comes back in few days afterwards, if you do the same, can you find the target to be exactly in the same area, or the target could be moving in different places? So are you discussing about the one single target, or is it a moving target? So we need to show that these targets are reasonably reliable. And this is another kind of a stage of work that we do. We do brain imaging, and then after something like 2 weeks, we do brain imaging again. And we showed that from baseline data to replication samples that we do, there is a reasonable level of replication. And some brain activation, some of the targets could not be there in the quality that we had before, but many of them would stay in the same place in the group level. And even in the individual level, when we do baseline assessment and then we do replication, when we put them together, there are still some variation, but there is a reasonable level of consistency in terms of the target would still stay at the same area, so you can target them. Another challenge that we are facing in this area is, okay, how to do this level of optimization. So we have been discussing so far about how to optimally define the target, right? But target is not the only factor that you need to consider in defining the protocol. We have a new paper that we discuss about 4 dimensions of individualization or optimization. One dimension is target, right? The second dimension is about dose, how to optimize the dose of the stimulation. From the field of depression, so I do TMS for depression in a daily clinical practice, okay? And I can tell you, TMS for depression works. And I'm happy to do that for my family. I'm happy to do that for my kind of kids. So it is something that I have done TMS multiple times on my own brain. So I can tell you, whenever I run a trial and I want to do a stimulation, the first one who receives the stimulation is me. So I want to make sure that whatever I'm going to provide for my own patients, I'm happy to do that. Probably not for DBS, but for TMS at least, I'm happy to do that. Yeah, that seems a little bit scary for DBS. But at least for TMS, I feel it is reasonably safe that I'm happy to do it on my own brain. And I've done that on my own brain several times. And there are brain stimulation technologies I'm still not very happy to do it on my own brain. But TMS seems very reasonable. So from many studies in the field of TMS and my own clinical practice, you see that some of the patients, they respond in the first few days of the stimulation. But there are many patients that they need at least 20 to 30 sessions of stimulation to actually make benefit from the stimulation, okay? And there is a very nice study that they showed that the initial results in 7,000 patients with MDD, they showed that the initial result starts with 10 weeks of stimulation, but without 30 sessions of stimulation, you will not get to a level of sort of plateau for having a reasonable level of results. So it seems that we need to have enough dose to have response. And interestingly, in the field of TMS, there is no level of TMS that you will have a sort of toxicity. So there is no evidence that any level of TMS could give a level of toxicity to your brain, at least so far. And it seems that the higher level of dose that you can provide, potentially you will have a better results. Most of the addiction studies so far, I think, they are underdosed. And we definitely need to optimize the dosing. Dosing is definitely going to be a very important factor. The third factor is what we call a state dependency. And it is very, very important factor. When you are in different states, your brain connectivity is very different. As an example, if you do TMS for people who have depression, if they sleep under TMS, it doesn't work at all. Why? Because that specific connectivity between DLPFC and subgenual cingulate cortex that we are targeting is not connected anymore when people are asleep. So the state that people have, because in a state A versus a state B, there are different connectivities. And when you are doing the stimulation, connectivity matters. And multiple studies, they showed that you need to have people to a level of craving. You need to induce craving. You need to have them on the state of craving to have the intervention works. Because when they are in the state of craving, then those connectivities are actually there in the place. So you need to put people on that level to be able to have access to those subcortical areas. So the state is important. And many of even the protocol that received FDA approval for smoking cessation, it has a component inside that you need to expose them to smoking-related cues to activate their craving to be able to make an impact. Even for the OCD protocol, that is a part of the protocol. You need to expose them to OCD-related and make the anxiety go high and then do the TMS. And then you will have the impact. So a state is definitely important. The other factor that is very important is the timing and the temporal aspect of intervention. One kind of recent analysis that we are working on right now, we have, as I told you, we have the connectivities between subcortical areas like nucleus accumbens, ventral striatum, and frontopolar cortex and DLPFC. Interestingly, we show that these connectivities changes over the time from the people who are in their early addiction to those who are in their later time of addiction. How? Let me show you this, the next figure. So those who are in their, let's say, their first 7 years of addiction compared to those who are from the 7 to 14 years of addiction, compared to those who are in the over 14 years of using substances, the level of connectivity between these areas are different. So frontopolar cortex in connection with subcortical areas is mainly involved in the first few years of addiction. They have more impulsivity, they have more passion to use substances, but over the time, when you evolve in the process of addiction, you get to a level that is mainly DLPFC running the show. And then the people are just thinking about, okay, how can I find the drug? How can I kind of find a kind of a good place to use the drug? It's just mainly an executive task, not very much an emotional process. And then even there are ideas potentially, when we are discussing about frontopolar and DLPFC, those who are in their early phases of addiction, potentially frontopolar cortex could be a better target. For those who are in the later stages of addiction, potentially DLPFC could be a better. So even these factors are going to be important in terms of how to optimally do the stimulation. And the last point that one of the two last points I need to address today is the issue of comorbidities. We know that we already have FDA approval for doing TMS in depression, anxiety comorbid with depression, and OCD. How many patients that you see in your daily clinical practice in addiction medicine that they have depression? Many of them, right? So many of them that you see, and many of them are actually treatment-resistant depression. So you have done multiple different treatments for them, provided different medication, they have not been responding. They are actually eligible to receive TMS and neuromodulation because of their comorbidities. And interestingly, most of the studies so far that they have done things for TMS and other things, they actually excluded people with substance use disorder. But few pieces of evidence that we have, TMS works in people with substance use disorder and those who have comorbid anxiety or depression or OCD, as well as how it works for people without having substance use disorder. So definitely comorbidities could be a good target to start working in the field of addiction medicine using brain stimulation technologies, as we already have those FDA approvals, and insurance companies are already covering that. So that is what I do in our kind of intervention psychiatry program, because in our program we have some of the giants of the field in the program, so they are doing the people with depression, but most of the clinicians in our clinic, they really do not like to touch people with addiction. Right? So they say, oh, these are the complex cases, so we usually do not do the TMS for people with addiction. But that is the specific niche that I really like. So I really like to work with that specific group of people. And it works reasonably well. So that is definitely a good option. There are specific clinical considerations. There is a new publication in the American Journal of Psychiatry in terms of how to manage concurrent depression, OCD, psychotic disorder in people with substance use disorder, and how to use TMS for them specifically. I really like some components of this protocol, but there are pieces that are not realistic. So, for example, they say, okay, if somebody is drinking alcohol, ask them not to drink alcohol for a week and then start with the stimulation. And you say, I mean, are you really seeing patients with alcohol use disorder in your clinical practice? It's not realistic, right? So you cannot just ask people to stop doing that and come back for the treatment. If it was the case, then, I mean, why we are here to just, yeah. So there are definitely some non-realistic aspect of the protocol. So we wrote a response letter to that specific paper, and hopefully the response letter is going to be published. So we discussed that, I mean, that protocol should be optimized. But they did a nice job in terms of discussing about some clinical consideration. But that is definitely a good starting point. So I think that specifically for the field of addiction medicine, for targeting the comorbid part, it is actually the prime time. So we can use neuromodulation, specifically TMS, for comorbid depression in people with substance use disorder, and there are definitely great clinical potentials, and insurance companies are covering that, at least in the US. So there are definitely potentials on that side. However, and interestingly, the protocol that we are using for depression is left DLPFC. So it is the same protocol that we are discussing for that could potentially be helpful for craving as well. So there are definitely rooms for using that in the actual clinical practice, and I think that I'm not making a specific recommendation, but it's just considering that in the future that could be a potential starting point, and then seeing how that is also helping their substance use and other issues. The last point, those who have been here on the Innovation Day, we had Anton from a group of people who kind of the society that they have for people with lived and living experience of substance use disorder. He made a comment about our presentation. Do you remember what was the comment? He said that your slides about brain stimulation is scary to me. Because talking about brain stimulation, people have a background in terms of it could be, it's important how you communicate that with your patient, how you communicate about brain and recovery with your patients. And that is an issue that we have been addressing, and we are working on that. So trying to develop a specific level of understanding about how addiction is impacting your brain, how addiction when your addiction is in the recovery process, how your brain should be recovered, what are the specific exercises that you can do, and giving people an understanding, a neuroscience-informed understanding about their brain and recovery, and then how neuromodulation could be helpful in this process. So this is a specific area that we are investing on, and we are developing new materials. The good thing is we already have them in 22 different languages. So we presented them in ISAM meetings a few years ago, and then many colleagues from around the world, they came and said, okay, we want to translate them into our languages. And now we have them in 22 different languages. And you are definitely welcome to translate them to other languages. We are happy to support them. And all those languages are already available free of charge in this website. And now we are developing new versions specifically for neuromodulation. Hopefully, we will be able to provide them. Specifically in Minnesota, we are developing a network of neuroscientists and people who are in recovery and in recovery communities trying to work together for innovation from the starting point and having them engaged in this innovative process and have them as a part of the process. Take home notes. You can have my slides in the QR code. Today we discuss about circuit-based therapeutics for addiction medicine, and that is an area for collaboration, education, joint research projects, and this is the reason that we are here. Colleagues from China, colleagues from India, colleagues from other parts of the world, how we can do things together. We discuss about targets, we discuss about dual target model, we discuss about the dose of the stimulation, we discuss about context, state, we discuss about the timing of the stimulation, the reliability of the targets. We discuss about comorbidities and the importance of comorbidities, and a neuroscience framework, because at the end of the day, it's not only neuromodulation. We also provide them with therapy. We also provide them with medications. How these interventions could work together in the same neuroscience framework, because we know how these medications are actually working on these circuits, how these therapy interventions are actually working in these neurocircuits, how we can have a unified neuroscience-informed framework that could inform all those interventions that we are doing in a same space, and how we can engage them together as a kind of as a holistic way of seeing addiction treatment. Discuss about importance of neuroscience-informed psychoeducation for patients, and also global collaboration. Few last slides. If you look into the publications in the field of neuromodulation for addiction medicine, only 22% of them are coming from the US. Almost the same amount are coming from China. And I was checking that just a few days ago, and it seemed that China is a little bit higher than the US as well. I mean, China is just going ahead of us, and then other countries, Italy, Iran, Brazil, Germany, so there are other countries that are collaborating together. So we realized that we need to have a network of labs working together. So we developed what we call INTOM network to collaborate together. So we have publications discussing about how to do this collaboration international level, and we already have 55 labs around the world that are working together to promote these international collaborations. We have a YouTube channel. Every 2 years, we get together in New York and discuss about how to promote the field. The next one is going to be in 2026. We had the last one in 2024. We have different consortiums, different technologies working together. And specifically within International Society for Addiction Medicine, there are specific potentials for this collaboration. So in the first day of conference, we had 1 day discussing about innovations, and you are definitely welcome to be a part of that collaborative network. And thank you very much for your attention. Okay, I can take a few questions, please.
Wonderful, wonderful. Just a comment. Would you please to organize an international network or team that we can cooperate for dealing the 5 practical challenges in the neuromodulation? I think this is very important.
Yep. We definitely need to put our forces together. And we do not, I mean, what you have done with DBS is just fantastic. There are a few other teams in the US that are doing that, but they are very smaller trials. So we need to bring our forces together. So that is the hope that we have for the future in terms of developing specific working groups and see how we can have a roadmap for the next 20 years and say, okay, Samir India, so you can address these issues. You are going to be focused on that. Then way you are doing this, and how we can bring those forces together, because I mean, if we do those things separately, we might not end up to the best result. So I'm hopeful that in 10, 20 years, when we get back here together, we can say, okay, in 10 years, we have been able to synergistically collaborate together to find a solution or find better treatments for people who are suffering from drug addiction.
It is time to have international consensus how to optimize our neuromodulation therapy. It is time for make a consensus.
Absolutely, absolutely, and I totally agree.
Please initiate this consensus.
Yeah.
We will follow you.
We are ready to, that is the reason we are here, right? So that is the reason that we want to do these collaborations. And there are definitely potentials. And I really like to kind of bring those forces together. Meanwhile, the things are changing. So I think that we need to also have a level of collaboration within societies as well. So we already have president of ISAM here. And it's important that we can even consider for guidelines in the future. When there is a publication in American Journal of Psychiatry about that specific issue, why ISAM is not being consulted, and why there are items there that are not realistic from addiction medicine point of view. How we can consider those, because field is moving forward. It would be nice if we can have collaboration between ISAM, CSAM, Chinese Society for Addiction Medicine, how we can bring our forces together for developing international guidelines and roadmaps and collaborative matrices in the future. Awesome. Thank you very much for your attendance.